I'm Sagar Lonial, and I'm here with Blood Cancers Today, and we're going to talk a little bit about the impact of recent data on CAR T cells and how to incorporate them into your daily practice. I'm joined by two esteemed colleagues.
My name is Noopur Raje. I work at the Massachusetts General Hospital Cancer Center in Boston, and I'm really excited to be talking about the T cell directed therapies in multiple myeloma today.
And I'm Krina Patel. I'm an associate professor at MD Anderson Cancer Center in Houston, and CAR T is my favorite thing. I'm not biased at all. So thank you for inviting me.
So, I think we've talked a lot about the clinical trial data, management, adverse events. I think we've covered most of the toxicity issues that people should be aware of. Let's talk real world data and what we know for either CARs or bispecifics. And why don't we start with CARs?
Sure. Yeah, I think there's a U.S. consortium, cell therapy consortium, which I think is about 15 centers that have been able to pull data together so that we can at least look at a higher number than the clinical trials. And, last year, the Karma cilta-cel or Karma ida-cel comparisons were done, and thankfully, the response rates are actually pretty high. It was still 86%. And again, these were patients that 77% of patients wouldn't have been eligible for Karma, mostly because of their history of BCMA therapy, usually an ADC at that time, but also cytopenias, cardiomyopathy, renal failure, all these things. So to see a high percent of patients actually responding was pretty impressive. The PFS was a little bit lower. It was 8.6, 8.7 months. Still, compared to our mammoth locomotion, and BCMA refractory patients already, still pretty impressive. But I think the safety was what we were really worried about, that they were taking these patients who are so frail. Right. Are we going to be able to do it? And it was very similar. Grade 1, 2 CRS, not much grade 3, 4. Mortality, there was a few patients that died, but again, COVID infections, maybe a couple of patients at HLH, CRS, but very similar to clinical trial data. So that was nice to say, okay, this is real patients can actually get this, not just clinical trial patients. And then we just had the cilta-cel update for the last year at ASCO and EHA, and same thing. The response rates or about 86, 87%, so a little bit lower than the 98% on the trial. But again, these are patients, 57% would have been able to go on cilta-cel or on Cartitude. And again, we don't have a PFS yet, it's early data, but just really impressive in terms of, the ability to actually give this to patients and have similar response rates to the trials. And I think safety, again, this is where we actually saw the facial palsies and other things that we hadn't seen on the trials as much. And everyone sort of talking to each other, how do you do this, how do you learn, and hopefully getting more information out there. And I'll say the renal insufficiency piece, there's a specific paper on that coming out soon, even patients on dialysis. And in that paper, we actually have how different centers do it differently. So hopefully one day we can get a consensus of how to do it, but there are ways to get patients with renal insufficiency through LD chemo. The only thing I'll say is those patients specifically end up with cytopenias for much longer, usually. And my patients at least have had better responses for longer too. Their PFS is better because I think they got better lymphodepletion. But the cytopenias part is a little bit longer to manage for them.
Yeah. So no, I agree with you completely. What to me was striking was real world data sort of reproduces the clinical trial data, and we don't see that often enough, Sagar. So this is very reassuring. You can give it to patients, all kinds of patients, bulky disease and so on and so forth also. And you're seeing pretty similar data results. With the bispecifics, the question that you asked about bispecifics, we just have the most recent bispecifics we recently approved, so we don't even have data with those. We do have a little bit of data with tech. Some of it is in the process of getting published, so it's not quite out there, but there is going to be more and more real world data, and I think every institution is learning how best to give these bispecifics. We all have our own ways of doing it. As of right now, with teclistamab, at least we are hospitalizing patients for that first week, and we're trying to move this very quickly to outpatient. Now that we're going to have choices, we're going to have elranatamab as well as teclistamab. The dosing schedule is a little bit different. The timing of toxicity is a little bit different. And I think we're going to be able to play with these drugs a little bit differently, which goes outpatient, which is very similar to what we saw with ida-cel and cilta-cel.
Right.
Yeah, no, I completely agree, because we do everything inpatient right now too. So hopefully that'll help us, do that, the management part of it.
Yeah, what I thought was interesting, speaking to the correlation between real world and trial data, in the ide-cel real world experience, if you were eligible for the trial, your PFS was actually longer.
Better.
Whereas if you weren't eligible, it sort of followed what the trial did. Now, again, the numbers are small and it was early data, but I found that fascinating that it's not just as good, it may actually be a little bit better.
Right.
Yeah.
Again, patient populations, right?
Yeah.
And who
Yeah.
who is eligible, who's not. But I agree. I think some of my patients have done much better than the clinical trial. I have patients that got it in August of 2022 or 21, whenever we had
Right.
it. They're still in CRs.
Yeah.
Right? And again, we can use bridging. That's
Mhm.
different and actually control disease. Where on that trial, I think less than 10% of patients on Karma actually even responded to bridging or
Right.
had even stable disease. Like
Right.
most were increasing.
Yeah,
So
we weren't allowed to use anything which they hadn't seen
Right,
before, and these
so-
were such refractory patients, so
Exactly.
that was such a tough population to treat.
Exactly.